Hello and welcome to Health Matters on Channels Television. Thanks so much for joining us. I am Mary Alale Yusuf. The first antibiotic, salvarsan, was deployed in 1910. Antibiotics have since then changed modern medicine drastically and extended the average human lifespan by 23 years. Now, antimicrobial resistance, AMR for short, is threatening to erase these gains. Every year, antimicrobial resistance causes 1.27 million direct deaths and is associated with an additional 3.7 million deaths. Antimicrobial resistance has been ranked among the top 10 global public health threats facing humanity. Most of the AMR burden is in low and middle income countries, accounting for nearly 90% of the direct death toll, and over 99.5% of AMR-related deaths among children under 5. According to the World Health Organization, there are 15 priority antibiotic-resistant pathogens causing the greatest threat to human and animal health. 4 of them have been found in Nigeria. My guest on the show today is Coordinator, Infection Prevention and Control Program and Chairperson of the Antimicrobial Resistance Program at the Nigeria Center for Disease Control and Prevention. Dr. Tochi Oko, you are welcome to the show. Thanks for coming.
Mary.
Yeah. Why do we have AMR at all? What is causing antimicrobial resistance?
Thank you, Mary. I will answer your question with a story. Give me 1 minute to paint a picture.
Go ahead.
The things that we use antibiotics for are things like wound infections, urinary tract infections, up to complex surgeries, making pregnancy and delivery safer. But gradually, we are losing the ability of those antibiotics or antimicrobials to take care of these infections that they normally will take care of. And the reason is that the bacteria, the fungi, the parasites that usually these antimicrobials will be able to kill, that is, those germs that these antimicrobials would normally take care of when you take them, we are losing the ability of these antimicrobials to take them. Meaning that when the antibiotics that you normally would take, when you take them now, it is no longer effective. And it is a big problem because it is unraveling all the excellent job that mankind has done in discovering these antibiotics or antimicrobials.
Now, why are they losing this ability? Is it because of what we experienced, during COVID, when you'd say, oh, there's a new strain, or there's a, there's a way that the COVID has changed, that it's changing because it wants to stay? Is that the reason? Is it that these microbes are changing, they're adapting?
Thank you, Mary. There are different factors. There are various factors. First of all, once an antimicrobial is developed, it is clear that the microorganisms themselves have what we call inherent mechanisms in them. Some of them have inherent antimicrobials. That is why every antimicrobial does not take care of every sort of infection. So we have what we call intrinsic resistance mechanisms. And then you then have those ones that the organisms themselves, either through mutation or through the transfer of resistant mechanisms from one microorganism to the other, it occurs. But the question is, what puts pressure on these microorganisms to begin to develop this resistance? They are the actions we take as human beings, either in the way we produce food, either in the way we use antimicrobials in agriculture or in the way we use antimicrobials in healthcare, and also the way we discharge the antimicrobials through the different human activities into the environment. So it culminates in this interplay between human, animal, and environment that continues to put pressure on these microorganisms to continue to develop resistance to the antimicrobials.
So what you're saying is that the antimicrobial that farmers give their animals to treat maybe some disease or the other, or that they put in crops, can translate into a human resistance?
Yes, humans, animals, our plants, we are in this beautiful harmony. We are supposed to be in this beautiful harmony with the environment. And therefore, the actions we take, either as human beings or in animal husbandry, in rearing our crops, can impact the environment, and then resistance can actually move through this system. And I'd like to say that the antibiotics or antimicrobials that are used in animals are often the same molecules, the same type of antimicrobials that are used in humans. So the pressure that starts from resistance from animals placed on the organisms in the animals will eventually translate and begin to impact human beings. And that's why we say that the approach we take in combating antimicrobial resistance is a One Health one. One Health acknowledging that the things we need to do, we must address them in the human health sector, we must address them in the animal health and the food systems, and we must also address them in the environment. We cannot look at one independent of the other.
Is this also partly because people don't want to go to the hospitals and they self-medicate? Is that a factor here?
Yes, it is a factor. The factors driving antimicrobial resistance are multiple. There are many of them. There are the human health factors, and you have mentioned one of them. When we are sick of an infectious disease and do not go to hospital for the right type of test to be done, because it is the right type of test that would let the doctor or the clinician know exactly the right type of antimicrobial to prescribe for such an individual. So when we do not go to hospital, and there are so many social determinants of health that impact our ability to go to hospital, from even our ability to pay for healthcare. So we acknowledge that the reasons why people may find it difficult to access healthcare are multiple. But yes, it does contribute. And even when people get to the hospital, doctors must understand, healthcare providers will need to know the right type of tests to prescribe for such patients, to go and do the tests. And this then means that we need to have functional laboratories that are able to do good quality tests to give the right type of results after we've done what we call susceptibility testing, to say specifically, this is the organism causing this particular infection, and these are the antimicrobials, these are the antibiotics that this organism is susceptible to. That is what will give the clinician the options available to prescribe for those patients. So what you see that due to access issues, when patients are not able to get to hospital, or when they get to hospital, they don't have access to these labs, it continues to drive antimicrobial resistance.
Well, you see, that is the fear. People say, why should I go to the hospital when I can take such and such and the thing will clear away? Because it's going to waste my time, and then it's going to waste my money, And I've had this kind of thing before, and I know if I take this, it takes care of it. So are there plans to improve access to hospitals and care and tests, and also to make it more affordable?
Definitely. I'm sure you understand that the government of Nigeria recognizes its stewardship function and responsibility to its citizens. And that is why there's a lot of talk now about universal health coverage, working to make sure that Nigerians continue to have improved access to healthcare. But to that argument that I will not go to hospital because it's a waste of my money, or I will take what I've taken before, I'll respond to that. One thing we've observed and one thing that has been established is that often what we think that ails us as patients, for which we say we want to take antibiotics, sometimes they're not even things that antibiotics or the antimicrobials we are taking will take care of. For instance, somebody that has a common cold or has a certain type of infection that gives certain symptoms, but is caused by a virus. If the individual sits at home and doesn't go to hospital and begins to take antibiotics, what that is contributing to is increasing the pressure for development of resistance without offering any efficacy at all to what ails such a patient. Then secondly, to your point of how do I pay, it has actually been found that the reason why often people don't do this test, it's not so much a matter of people just believe that there really is no point in having to do these lab tests. But once a doctor has recommended a lab test, we must make every effort to have those lab tests done. The reason is that what you're running away from here might very well be waiting for you down the line when you really, really now need an antibiotic, and you find out that all the options available for you to take that antibiotics is no longer available because they are all now resistant.
That is frightening. Now, I was a bit surprised to see the numbers, attached to children for AMR, children below 5. I'm surprised because I thought AMR needs time to develop. And these are children who have not come in contact with so much. Why is it so much in children? And what can we do about it?
Excellent question, Mary. And to that, I'll first of all establish that the thing with antimicrobial resistant is that once an organism, a microorganism, is a drug-resistant microorganism, anybody that microorganism infects will automatically be infected with a drug-resistant microorganisms. And children, particularly neonates, children under 28 years, the first few weeks of life, the first few days of life are the most vulnerable for children. And then when you then factor in children that are premature and needs to be taken care of in the hospital environment, you can begin to understand the numbers you just mentioned. The hospital environment is an environment where the risk of getting drug-resistant infection would then be slightly higher. And then these vulnerable children are taken care of in such an environment. If they get an infection that is drug-resistant, it is not within them that drug resistance is developing. It is that the organism that they are now exposed to are drug resistant. So Mary, you imagine that for such vulnerable young ones, because they have been infected with drug resistant or the infections that are caused by drug resistant organisms, the antibiotics that are now prescribed for them will not be effective. So you might see a baby that is just a week old, a couple of days old, would go through 4, 5, 6 antibiotics just because the doctors are struggling to save this baby's life and are struggling to find an antibiotic that works. So that is one more justification, one more motivation why we as a society must realize that we must do something to begin to combat this menace of antimicrobial resistance.
Okay, doctor, let us take a short break. When we come back, I really have a few things to tackle with you. Please stay with us. We're going on a short break. Talk on urgency of antimicrobial resistance. This is Health Matters on Channels Television. You can call 0808-054-2233 for your questions on the topic. You can also get me on X at CTV_Mary A, or send email to moalale@channelstv.com while the program is on. Thank you for staying on, Dr. Okwo. I want to ask you, experts say that going to unlicensed pharmacies or hospitals can also be a problem because perhaps of substandard formulations and all that. How do we recognize what is standard and what is safe?
Okay, well, first of all, Mary, a starting point, and this is part of the work we are doing at the Antimicrobial Resistance Coordination Committee in Nigeria and in the Antimicrobial Resistance Program in Nigeria, is working on the areas of regulation and looking at quality. Unlicensed people, unlicensed practitioners are really not supposed to open shop in the first instance. So you will see that a lot of work is being done by the councils, the Pharmacy Council of Nigeria, the Medical and Dental Council, the Medical Labs and Science Council. It is in that way that we're organizing nationally through the Antimicrobial Resistance Coordination Committee to deliver on that promise to Nigerians to improve the regulation in those sectors. And a lot of policy work is going on in that area. That's one side that I would like to put out there. A lot of work is being put out there to understand these dynamics and what is making these, what is driving these poor practices. That brings us to the area of quality. Even among licensed practitioners who do have the license to practice, there's often the issue of quality. So a lot of work is also going on in the country to make sure that the laboratories that do this testing meet certain quality characteristics that a lab needs to meet. And it is only when this is guaranteed that we can begin to assure ourselves that the quality of lab tests that is coming out is what really would help us to make good diagnoses and inform the prescription of these antimicrobials.
Okay,
the second part of this is...
Let me cut in there just for a moment. We're having a call from Ada. Hello, Ada,
yes,
in Jos.
Good afternoon, Mary and your Dr. Tochi. I was listening to
Good afternoon.
Ada calling from Jos State. You see, I said most of the things, actually. We have a problem in this country. I even had a personal experience, I went to the facility, medical facility, and the lab is there, but the lab is not functional, and then they have a backlog. They said they don't have the reagent or whatever to do that test, the particular antibiotic or whatever they will give. So they said, come back in 2 days' time, come back in 3 days' time. That's what they were telling patients. So what will they advise? That's what makes people to go out to the pharmacy and get medication. So we just have to do something about it. I learned the federal government was talking about 2030. 2030, won't we all die by then? Or they said, let's not give up on Nigeria. It shall be well.
Thank you so much, Ada. Dr. Tochi, she's talking about a lab that had a backlog and they told her to come back in 2 days. And I want to just add something to that. The question I wanted to ask was, in other crimes, people have complained that, they have these long lines, they have to do these tests, and the condition is getting worse. A week has gone by, 2 weeks have gone by, and then I hear people here saying, thank God I'm in Nigeria and I'm in Nigeria. I can just go to the pharmacy and buy whatever. That so and so died while they were doing tests on her before they got to what really was the problem. The case was so bad, blah, blah, and all that. So here is Ada now talking about how she got to a place and they told her they can't do the test. The reagent is not available. Come back in 2 days. Have you considered all these ramifications?
Mary, first of all, I lost internet briefly, so I didn't get the full some aspects of your question, but I got the other part. I would like to say that there's this constant push to continue to improve the quality of healthcare delivery in the country. one is not oblivious of what the challenges are. And that is why incorporated into the National AMR strategy is also addressing the issue of the health workforce that is needed to begin to take care of some of the challenges that you have mentioned. We are working very hard to increase the numbers of microbiologists and lab technicians who will work in these labs and begin to shorten the time for delivery on those tests, and also improve the numbers of clinicians who will support to make sure that people actually get the right prescriptions for these tests. So those challenges are there, but it's a constant everyday work to overcome those challenges. The quality side of things are also being addressed. So for the patients, I would say that usually when these lab tests are done, it is very, very important that the samples are taken to the lab before even the first antibiotics is given. And if that is not done, what it means is that what you might be seeing in your lab results may not be the true picture. And understanding that some of these challenges are there is also why we are working very hard to strengthen what we call antimicrobial stewardship in hospitals and supporting hospitals to have their drug formularies to guide clinicians to make some of these prescriptions even while they're waiting for some diagnosis, but factoring in what the patterns have been in the hospital. But as much as possible, it is always better that these lab tests are done before the prescriptions are made. Mary.
Okay, I think we have a call from Mark. Hello, is Mark there?
Yes, Mark is here.
Okay, what's your question?
Yeah, thanks for this program. I'm enjoying it. Ask your guests the attempt they are making to use efficient clinical microbiology mediums in their program, because this question is necessitated. Some years back, there was a pollution of, a contamination of milk, milk for infants. And that milk was already in the country before it was detected in Paris. Even when NAFDAC announced it, it was picked from the findings in Paris. And the guys in Paris only used 1 million chromometer to be able to get their findings. I was discussing with a director in NAFDAC, and he doesn't even understand what chromometer is.
Okay, I think I lost you there, Mark, but I understand that you're asking about controls at the border. So I'll put that to Dr. Tochi.
Apart from the control, when these items come into the country and they are in various shapes, we know that we have a porous border. What are the efforts NCDC is doing to isolate, find out these things in various supermarkets where they are, randomly tested?
I'm sure she's ready for that. Dr. Tochi, do you go around but I think, isn't that NAFDAC's work to really go around and test things? But then you would be probably working in close consonance with them. Let's know.
Okay, thank you very much. And to the question he asked, he was breaking up, but I got a sense that some product that went through the border, it wasn't detected here, it was detected in Paris, and it appears that, to his own understanding, what the issue was that the labs in Nigeria tested it didn't have Promega to do some things in the microbiology lab. And he was not asking about, how do we check to make sure that the products in the shelves in supermarkets meet certain standard. And to that, I will say that the way The approach we have taken for AMR control in Nigeria is the one we call a One Health approach, meaning that we do acknowledge that the antimicrobial resistance issue is a multifactorial one, and therefore we must bring all the relevant stakeholders to the table. And to that point, I'll say sitting at the table at the level of the Antimicrobial Resistance Coordination Committee in Nigeria are all the relevant ministries, departments, and agencies, NAFDAC included. And we are now working very hard.
So I'm getting the impression that, sorry, you're going to roll up your sleeves and join all these other people to make sure our health is safe. I'm cutting in because we're out of time. Thank you so much, Doctor, for coming to the program. It's been wonderful having you.
Thank you, Mary.
And thank you at home for being with us, at home, at work, wherever you are. You can watch us all over the world. Thank you for being there. Have a wonderful day. I'm Mary Alale Yusuf.